All right.
We can get started here. Hi, everyone. My name is Marian, one of the co presidents for Brown Skin Health. Our team would like to thank all of you so much for coming to our very first live Zoom session. I know a few people are still trickling in, but we're so excited to have all of you here. And today we have Dr. Aegean Chan, who is a dual board certified dermatologist and dermatopathologist, talking to us today about her specialty and experiences working with skin of color. We're so grateful to her for coming and sharing her knowledge with us today. So, Dr. Chan, whenever you're ready, I'll go ahead and let you take the floor.
Great. Well, thank you for that introduction. Again, my name is Aegean Chan, and I am so happy to be here to kick off this lecture series. I think it's wonderful that you guys are kind of doing this grassroots movement to really bring awareness to issues in the skin that really disproportionately affect people of color. And so I chose the topic hidradenitis suppurativa, otherwise known as HS, to talk about because this disease is really overrepresented in people with skin of color, yet it's very underrecognized and undertreated. So I think it's really important to increase awareness about this disease. And no matter what specialty you guys are going to go into, you probably will encounter this disease. And it's just a matter of recognizing it and getting patients appropriately treated. So let's just dive in. I have no disclosures. And so, just a little bit more about why we're talking about HS today. So, there is an increased prevalence of this disease, particularly in African Americans, but also in other people of color. And I've seen this firsthand. I did my training at the Albert Einstein College of Medicine and the Montefiore Medical Center, which is in the Bronx, New York. And so, we primarily served a community of color, and I saw so many patients that came in to the ED, to primary care clinics with this disease that had been just cursorily treated over many years, sometimes decades. And these patients had progression of their disease, years and years of psychosocial implications from the disease, depression, shame, social isolation, as well as associated pain and substance abuse issues. And what really bothered me was that this disease, if accurately diagnosed, is really treatable in early stages. So we could prevent all of that negative sequelae if, first line providers like emergency medicine physicians, urgent care doctors, primary care doctors can accurately diagnose this disease. So well, let's just start with a case. So say you're in the emergency room and you have a 33-year-old woman that comes in complaining of multiple painful nodules in her bilateral axilla. She says it's draining, this malodorous pus, and she says this happens every few weeks and it's been going on since she was a teenager. Her past medical history includes polycystic ovarian syndrome. And when you examine her, she's well appearing. Her vitals are completely normal. She's afebrile. Basic labs don't show any signs of infection. And when you do your physical exam, you notice few open, draining, erythematous tender nodules in one armpit, and there's some surrounding scarring. So you know when she tells you that this is a recurrent process for her, you see evidence of that as well. On her other axilla, you see a scarred down sinus that she says becomes periodically tender and drains as well. So, what is your treatment plan as an emergency medicine physician? Are you going to just do an incision and drainage of the active lesion? Are you going to do an IND plus a topical antibiotic? Are you going to give her just a 10-day course of antibiotics, assuming that this is just a soft tissue infection and it should go away and resolve on its own? Or do you do a longer course of doxycycline as well as give her a referral to dermatology? And we'll go into the answers after I talk more about this disease. So, hidradenitis is a chronic inflammatory, and this is the definition from the Aegis Foundation. It is a clinical diagnosis, and again, it's a chronic inflammatory, recurrent, debilitating skin follicular disease that usually presents after puberty, and it presents with, as our patient did, with painful, deep-seated, inflamed lesions in the apocrine gland bearing areas of the body. So this is most commonly in the axillary folds, inguinal folds, and anogenital regions. And so for your reference, apocrine glands are different from eccrine glands. Apocrine glands are specialized and typically only found in certain areas of the body, like the axilla, the inguinal area, and anal genital regions. And they secrete an oily substance that gives us body odor, essentially, or what we call pheromones. So let's dive into why this matters and a little bit more about why we're talking about this today. So globally, the numbers are kind of all over the place. There's not a lot of great data, but the numbers range from 0.003% to 4.1% prevalence. The largest cohort in the US showed that the prevalence was 0.1%. This is much more common, twice as common in women than in men. And again, why we're talking about this today is that it's 3 times more prevalent in African Americans and 2 times more prevalent in biracial patients versus Caucasian patients. So that is a big difference. So how is it presented? So we saw an example of it in the case. Again, it's a clinical diagnosis, and typically you want to see around 5 or more typical lesions. So typical lesions are these inflamed tender papules. Sometimes they can be more deep-seated nodules and abscesses that drain a pus-like fluid present in flexural sites, so the folds. And this is going to be recurrent over time. So it happens commonly in the axilla, but also under the breasts, in the inguinal folds, and also in the buttocks. So anywhere there's folds and recurrent friction. It's important to note that on average, there's a 7.2-year delay in diagnosis. And you can imagine having this kind of disease doesn't have a high mortality rate, but the morbidity associated with these painful recurrent lesions, recurrent scarring, it's pretty awful. Like, can you imagine having that for 7 years, sometimes more, without being adequately treated? So these patients do have a lot of suffering. And so usually it starts with, again, this typical erythematous nodule. Once it becomes more recurrent, you can start to form these epithelialized sinuses in the folds. Those are, can permanently fill with pus. They can drain, they can be permanently tender, and you can also get new nodules. After several years of this continued disease, if it's not well treated or controlled, you can get diffuse scarring, and you can see with that much scarring, there's mobility issues, a lot of pain. You have functional issues as well. And again, the last picture is an example of it present in the inguinal folds. And I want to point out that, as I was putting this presentation together, it was really difficult for me to find pictures of this disease in people of color. And I thought that, that really highlights the practice gap, the gap in knowledge that we have about this disease, because it's so much more prevalent in people of color, yet it's so difficult to find pictures of this entity in the patient that it happens in the most. So staging. So staging is really the best way to categorize this disease. There's multiple different staging systems, but the Hurley stage is the most common and the most reproducible. So mild disease, we call Hurley stage 1, and you get single or multiple isolated abscesses without any sinus tracts. Hurley stage 2 is what we call moderate disease, where you have recurrent abscesses with 1 or more sinus tracts and scarring, and you do have areas of separation of normal skin. And you can see in this middle picture here, you can start to appreciate kind of dilated pores as well, and that's pretty characteristic of that. And then Hurley stage 3 is severe disease. So that's when you have diffuse boils and multiple interconnected sinus tracts and no intervening normal skin. So again, you could see you can have some mobility issues and a lot of pain and scarring with that. So before we dive into treatment and what we do with our patients, it's really important in medicine in general to know and understand the pathogenesis. And from there, you can really target treatment. So the first step of HS is follicular occlusion. So this is not a primary infectious process. So that's the most important thing to remember. And that's the biggest obstacle to diagnosing this disease is that these patients always get put into the infectious bucket. So in the emergency room or urgent care, they always get a short course of antibiotics and get sent home. But if you understand that this is actually a primary chronic inflammatory disease, you understand these patients need they need to get plugged into longitudinal care, and also need to be treated with multiple modalities. So this follicular occlusion, you can have a genetic predisposition to the follicle getting plugged up. And we know this because most HSS patients, 30 to 40%, have at least one relative that also has HS. And then if you are a smoker or you're obese or again, you have a lot of mechanical friction in certain areas, that can also exacerbate this plugging of the follicle. And a certain microbiome, makeup of the microbiome can also make this worse. So once that follicle is plugged up, that follicle fills up with debris, bacteria, oil, and the follicle will eventually rupture into the dermis. That's the middle layer of the skin. And that rupture will trigger a inflammatory process where you have a release of cytokines, and those cytokines attract inflammatory cells to the area. Those inflammatory cells release more cytokines. So it's this positive feedback loop, and eventually you get to this chronic state with sinus tracts that are permanently there. Often they're colonized with a biofilm. There's chronic inflammation and scarring again. And I'm not going to go through everything that in this really busy chart, but this is just to illustrate to you how complex the pathogenesis of this disease is. And this is what we know so far. There's still a lot of work that needs to be done. But again, here starting on the left, you can see those are some of the genetic defects that have been identified to be associated with this disease. So if you are a carrier, you are more genetically predisposed to having gamma secretase defects, which alter your immune function as well as make it more likely for your follicle to get plugged up. You have a certain bacterial colonization that is pro-inflammatory. And then again, you have this upregulation of certain cytokines, in particular, tumor necrosis factor alpha, IL-17. These kick off a cascade that attract macrophages and neutrophils to the area. So that malodorous pus, it's not from a bacterial infection. It's actually mostly neutrophils that are coming to that area that give you that cloudy discharge. And then if you're a smoker, that also exacerbates the hyperkeratosis in the opening of the hair follicle and leads to plugging of the follicle. And then hormones also play a role. There's a subset of patients that note that this gets worse during their menses. So keep that in mind when we talk about treatments. There's not one magic bullet because you see how complex this pathogenesis is. We need to use multiple types of treatments. So what about bacteria? This is fascinating. So the studies that have been done show that HS patients have a unique microbiome. So they have an increased amount of Corynebacterium, Porphyromonas, and Peptinophilus species, and these are organisms that are found in chronic wounds. So the thought is that this is kind of perpetuates this pro-inflammatory state. I talked briefly about these biofilms, but ultimately more research is needed. We don't have a great picture of specifically what bacterial species are most common in the HS. So that's a knowledge gap that we have. So it's also important to note, because this is a pro-inflammatory disease, so this is in the same category as rheumatoid arthritis, psoriasis. If you have this inflammatory alteration, you can also have other associated diseases that are also pro-inflammatory in nature. So obesity is most commonly associated with HS in these patients, but these patients often can also have hypertension, metabolic syndrome, dyslipidemia, polycystic ovarian syndrome, adverse cardiovascular outcomes. So it's really important, especially if you're a primary care physician, but even if you're a dermatologist, to screen your patients that have these pro-inflammatory diseases for these other comorbidities. There's a strong association between HS and tobacco smoking. And we know that patients that are smokers, they have more recalcitrant disease and their disease is more severe. So the first thing you want to do is counsel your patient, get them to stop smoking. Interestingly enough, there's a lot of overlap where there's increased prevalence of patients that have HS and also have psoriasis. So there seems to be some sort of pro-inflammatory link there. And then also the genetic link, another clue to the genetic link is that this is one condition that's in the follicular occlusion tetrad. So there are certain patients that have severe acne, dissecting cellulitis of the scalp, pilonidal cysts, as well as HS. So they're kind of all they're all inherited together. Another comorbidity to keep in the back of your mind is that patients with long-standing, poorly controlled disease have a 4.6% risk of squamous cell carcinoma developing within their wounds. And this is common in chronic ulcers as well. You do have an increased risk of squamous cell carcinomas. And when I was in the Bronx during training, I saw a lot of patients with severe HS that had not been treated for decades, with massive squamous cell carcinoma tumors within them that were inoperable. And it just broke my heart because these are all avoidable if these patients got treated earlier. So the most important piece of this are the psychosocial implications with the disease. I already talked about it a little bit, but again, this is not a very life-threatening disease, but it has a dramatic decrease in the quality of life of these patients. So even patients with mild disease have a lot of shame. They avoid social activities. They avoid physical activities. I mean, imagine you can't lift up your arms. Imagine if you're draining malodorous fluids, you're really self-conscious. So a lot of the treatment that you have with these patients also entails counseling and addressing these psychosocial issues. Depression occurs in about 6 to 45%, depending on what study you look at. So it is a high rate of depression. And a lot of these patients also have associated pain. And so that leads to increased rate of substance abuse, especially opioid abuse. There's a lot of pain seekers that show up to the ER, and again, the ER they're so inundated. They don't really know what to do. These patients, they, give them a little fentanyl, give them some antibiotics and send them home. And then these patients also have an increased rate of suicide completion. And, because this disease is more prevalent in people of color, we know that people of color also have an increased risk of other psychosocial issues, increased rates of depression. So this really, if you have this disease, it compounds all of that. So it's really, really important for us to really take care of these patients and recognize this disease earlier. So let's just dive into treatment in general, and then we'll go into what my treatment algorithm would be. So again, remember, it's not a primary infectious process. However, we do use antibiotics commonly as one of the first lines, not because it's primarily infectious, but because the antibiotics we do use also have anti-inflammatory properties, and it also treats the secondary infections, these bacterial overgrowths and the biofilms. So typically tetracyclines are first line, along with a topical antibiotic and antibacterial washes. So that's what I use for the patients with mild to moderate disease. Other combinations of antibiotics are also used. So rifampin and clindamycin orally are pretty effective for moderate disease. Rifampin actually suppresses T cell immune function, and clindamycin it actually acts to reduce complement mediated chemotaxis of neutrophils to the area. So it helps dry up sinuses pretty effectively. Again, because it's an inflammatory process, why don't we use steroids? So actually, intralesional steroids are really commonly used, typically for patients with more mild disease that have kind of painful inflamed nodules here and there. I will do intralesional injections on demand, almost as if, if you guys had experience of getting acne injections, it's the same concept. Some studies have looked at oral prednisone. I don't use that in my practice for this disease. The data is not really there for that. And then in the age of biologic medications, where we're really specifying the target, we know as I mentioned before, there's an elevated level of TNF alpha in HS patients. So adalimumab, also known as Humira, is the only FDA-approved biologic treatment for HS. But we also use infliximab infusions. But these medications are quite costly, so we typically reserve them for more moderate, severe disease. IL-17 inhibitors have some case reports that have shown they're successful. But again, when you remember how complicated the pathogenesis is of this disease, you can't just target one pathway. So the future is targeting multiple pathways at once, although it does get tricky, balancing the side effect profile of these medications. So the story on biologics, I think, is just starting in this disease. I think there needs to be a lot more work on that. So surgery is also a tool in our toolbox for this disease, especially for patients that have isolated sinus tracts that keep filling up. Surgery can be pretty effective. And remember, it's the hair follicle with the apocrine gland that is the target of this inflammation. So if you remove those areas, you can actually get pretty good remission of disease. There's nothing to become inflamed. So I've had some patients that have had their entire axillary vault removed, where they remove the hair follicles and replace that with a skin graft, and they've done very well with that. As I mentioned before, lifestyle modifications are very, very important. So talking to your patients about weight loss and smoking cessation. And all of these things, you see how many different treatments we use. The best way to treat these patients are in multidisciplinary clinics, where you have dermatologists that can help on the medical side, surgeons, dietitians, as well as mental health specialists to help these patients with the other sequelae of this disease. Again, I briefly mentioned hormones and an elevated androgen level can play a role. So especially in female patients that notice that worsens around their menses, oral contraceptives and spironolactone, which is an anti-androgen, can help as well. Retinoids have been used in the past, not that effective. And then in mild disease, laser can be very helpful, especially ND-YAG laser for hair removal. So again, if you're destroying that follicle, there's nothing to become inflamed. So going back to our patient, again, she's got these scattered, active draining nodules or furuncles, and then scattered sinus tracts. So I would say she's about a Hurley stage 2, so she has moderate disease and it's pretty chronic. And back to our answer choices. So would you guys do IND? Would you do an IND with topical antibiotic, a short course of antibiotics, or antibiotics until she can go see dermatology? So it's kind of tricky to do this over Zoom, but I'm sure most of you guys got to this answer. So we want to make sure for our primary care, urgent care, emergency medicine doctors, if you see a patient that you suspect has HS, don't just kind of say, oh, it's an abscess, IND packet, send her home. No, you want to make sure you get this patient plugged in. It's great if you can get them started on, doxycycline. That's a very well-tolerated antibiotic. Maybe do a culture just to give us a little bit of extra information, and then get them plugged in to see dermatology. And that is so important because 65% of patients with this disease, 65% of cases that are diagnosed by dermatologists are diagnosed at Hurley stage 1 and 2, so very mild disease, where that only happens in 35% of cases with primary care doctors. So dermatologists typically are more trained to recognize this at an early stage and intervene earlier thus preventing that long-term sequela. So again, you want to treat their active flares, but these patients really require continuity of care in order to prevent flares and to prevent long-term sequelae, again, such as scarring, SCCs, as well as all the psychosocial implications. So just to give you a sense of, my algorithm when I treat these patients, topical antibacterials and intralesional steroids for mild disease if you have a couple scattered nodules. And then if it's a little bit more severe, we'll do some oral antibiotics. Typically the courses are a few weeks to a few months. In dermatology, we do use antibiotics for longer courses because of the anti-inflammatory properties of the certain antibiotics we use. For moderate disease, you want to definitely do some sort of oral antibiotic. Usually the combination antibiotics are used with or without surgery. And then you want to discuss biologics as well. And then for severe disease, I would go straight to biologics. And then once things calm down, get them in to see a surgeon. So going back to how HS specifically affects people with skin of color. So we know that people that are African American and other people of color and females have an increased rate of HS, but they're also more likely to have recalcitrant disease, progressive symptoms, and are less treatment responsive. And we know that in all the clinical studies that are looking at these treatments, people of color make up a minority of the patients in these study groups. And that doesn't make sense, right? Because people of color are most commonly to be affected by this disease. So you actually want to have more data in that population. And then there's issues with access to appropriate care. So we know that African Americans go to dermatologists much less frequently than white patients. So we have access to care issues. Some of it is barriers to a provider. So there's not enough diversity of providers in dermatology to where patients feel comfortable going to see somebody that doesn't look like them and may not have cultural sensitivity to what's going on with them. So how can we do better? So like I said, we're lacking in research that's specifically focused on people of color. So we want to increase that type of research in people of color with HS. So larger population-based studies, and we want to look at how the treatments work, and specifically in people with skin of color, because they may, because of certain genetic things, different features of the disease, treatments may work differently, or maybe certain treatments may be less effective in people with skin of color. So we want to get more information on that. And we also, and I've talked about this, mentioned this a couple of times, but we really want to increase disease awareness so that across the board, across multiple specialties of medicine, we can have increased disease awareness so patients can get diagnosed earlier and get appropriate treatment earlier. So that includes increasing access to dermatology, early screening, getting them plugged in with longitudinal care. And so I really want to plug the HS Foundation. This is a great resource for clinicians as well as for patients that have HS. It gives you information on where multi-specialty clinics are located. And it also can connect patients with peer-to-peer support groups. And I found this was the most important thing for my patients, was really to get them with a group of other people that understood what they were going through. I think of the types of patients I see, most of my patients, I think 75% of my patients cry during their visits that have HS. It's really, really common because they just feel so isolated. So it's really important to connect them with that, make them so patients feel supported, feel like they're part of a community. And then again, you guys are probably all aware of this, but the Skin of Color Society is a great resource for a lot of diseases around people with skin of color. And then I just want to thank you guys again for inviting me. You can reach me through my website. You can contact me through there if you have any other questions. And I recently did a blog post just about various other diseases and issues that are pertinent to people with skin of color. So at this time, I guess we can go to questions. I can keep this up for a while. Do you want me to stop sharing my screen?
I think either is fine.
Okay.
It looks like we have some questions in the chat as well. Can you see them?
All
Or
right. Yes.
okay.
What do you think are some of the biggest barriers? Okay, so from Ashley, what do you think some of the biggest barriers to care that may prevent POC from receiving early treatment? So I think the biggest barrier to care is the lack of awareness of this disease, because if these patients get in to see a dermatologist, most dermatologists are aware of this disease and will treat it adequately. But I think primary care physicians, ER physicians, urgent care physicians don't know about HS, or they may have heard of it, but don't quite grasp the fact that it's not a primary infectious process. And so these patients get inadequately treated with a 10-day course of antibiotics, and they get sent home. And of course, it comes back, and they're often bouncing in and out of the ER. And when they get more severe disease, they have more associated pain. That's when they are just given opioids. And so it's just this endless cycle. So I think the biggest barrier is lack of awareness. So that's why I talked about this on my social media account, because, people don't really talk about this kind of stuff unless you're, in dermatology residency, you don't learn about it. Any other questions related to that? Okay. Oh,
Oh, I was just saying thank you. I thought it was really interesting how you're talking about how the lack of awareness, because there's so many conditions, and it's really interesting how, like if you don't address it early on, it can actually manifest into something much worse from the clinician's side.
exactly. And I think it's just a matter of increasing awareness of that. And it's just as easy as saying, okay, I think this is a derm thing. Let me just send it to derm. So if no matter what specialty you're going into, as a dermatologist, I don't expect you to come up with a complete treatment plan for these patients. But if you just have a general idea, this is a chronic issue, they should get plugged in, I think that will lead to patients having better outcomes. And I feel so strongly about it because I saw so many patients during training that had decades of severe disease that were admitted to the hospital for days at a time, putting them at risk for other hospital-acquired infections. A lot of them were addicted to opioids because there's that lack of awareness. And these patients do much better when they're plugged in with outpatient dermatology and have a regular dermatologist that they see. It's not a one-off disease. It's something I have to see somebody every month, every 2 months, and it changes. It waxes and wanes. Some months it's better than others. And so just having that safety net and getting them plugged in is really, really important.
Yeah, I thought it was really fascinating because like with people of color, if you look at a lot of those areas, you'll see that they don't actually have a lot of dermatologists as well. So it's kind of like sad because they don't have even access to that kind of main person who could even like if like assuming they're more knowledgeable about this disease could actually properly diagnose.
Yeah, I mean, there's definitely an issue with access of care to dermatology. We don't have enough providers. Again, that's why increasing awareness. And, it's pretty easy to treat it at its early stages. So even if we could treat 20% of mild cases, have the primary care doctor treat it, I think that would make a difference in a lot of people's lives. And I think telemedicine may also help with those gaps in care as well.
Thank you. I think you addressed my second question about your thoughts on telemedicine, teledermatology.
Yeah, teledermatology is tricky for primary diagnosis of certain rashes, moles, melanomas. That's really tough to diagnose over telemedicine. I typically use it more as a triage tool. So if it's a new patient that has something, it's not as much it's not that useful because the resolution's not that good most of the time. It's more about triage. So, oh, I need to see you sooner rather than later. Try this cream. If it doesn't work in a month, please come into the office. So it helps me kind of triage patients just to prevent overcrowding in the clinic. But for chronic diseases like HS and acne, patients that are already have a relationship with me and we're just maintaining their, and following their progress. If they're flared, we can change up their medication via telemedicine visits. So I think it is helpful in certain situations. And again, that may lower the bar to access, right? So it's not taking up as much office time. Another slot can be freed up to see somebody else. Or if somebody lives far away from the clinic, we can kind of manage their care from afar. So I definitely think that will help with access.
Thank you so much.
You're welcome. So let's go to this third question. So this is from Chelsea. What other skin conditions are commonly found in Black, Indigenous people of color? So this is a very broad question, and I think this is kind of what this speaker series is going to address. So, but just very briefly, one interesting thing I don't think people realize is that even common skin diseases show up, they look different on skin of color. So sometimes if you've trained in an area that's mostly white, you may not be as comfortable diagnosing skin disease in a person with darker skin types. So, if you are looking for a provider and you're a person of color, even if your provider may not necessarily be a person of color, if they trained in some place like New York or Washington, D.C., in an area that probably have a lot more people of color, then you can be more confident that this practitioner has seen and treated and has experience taking care of people of color. So just in general, hair issues are a little bit different in people of color, particularly people with African descent. There's certain types of alopecia and hair loss that are pretty much only seen in people of African descent. So one of them is called central centrifugal cicatricial alopecia. And all of this information is actually on the Skin of Color website. They have a great directory of things that are more prevalent in people of color. Pseudofolliculitis barbae, which is basically a folliculitis of the beard area, very common in African American men. The curly hairs kind of get caught and grow into the skin instead of out of the hair follicle and create this inflammatory response, and it can lead to scarring. Melanomas on acral surfaces are more prevalent on people of color. It's still very rare, but it's more common to find melanomas on the hands and feet and under the nails in people of color. Let's see. I mean, it's a very broad category, but those are the first, couple diseases that come to mind. Any other questions?
Go ahead. Go ahead.
Okay. My audio wasn't working when it first started, so I'm not sure if you answered this already, but is HS contagious?
It is not contagious. So remember, it's not an infectious disease. It's an inflammatory disease. So think about like rheumatoid arthritis or psoriasis. This is an alteration of your body's immune system, and it's just a hyperactive immune reaction that's centered around the hair follicles in your folds. And so you get inflammation in those hair follicles and the folds. Rubbing makes it worse. You can have secondary infections, but it's not contagious. So if you're sleeping in the same bed as somebody else, they won't develop HS.
The reason I asked is because I know someone who had something that looked similar to that, and it was contagious. Do you know what that might have been? It was in the fold of their armpits, and it got like the fold of their arm.
It's really hard to say. It probably was a different disease. So on the skin in dermatology, there's a lot of overlap between different diseases. So things that look similarly clinically may have different causes, if that makes sense. So it's all about, making sure that the person that you're seeing feels comfortable with the diagnosis, following up with your doctor. So it is possible you can have tinea, different rashes. You can have abscesses in the armpits, but if it's recurrent, if you have this kind of scarring pattern, HS, if you have HS as a diagnosis, it's not contagious. All right, this is also from Ashley. So, in terms of capture relevant data. So, I mean, I really think that, collecting clinical photos is really important, because if somebody is training in a place that doesn't have a lot of people of color in it, it's helpful to have pictures of diseases on people of color in the textbooks, if that makes sense. And I saw something on Instagram. There's a medical student that maybe put together an atlas of diseases, but using all pictures of people of color. So I think that's really helpful. And I think in terms of sharing surveys, contacting residency programs, so program directors, that's probably the best and easiest way of distributing surveys through dermatology. You might want to reach out to the Skin of Color Society as well, and see if they may want to work with you or collaborate with you on something like that.
Oh, I just wanted to say thank you. Would it be possible if I could also share the survey with you, and if you have any people who are interested to share it as well?
Sure. Yeah, you can just email me through my website. If you have a link to it, you can just email me through that.
Thank you.
You're welcome. So Marianne or Marion?
Marion.
Yeah. Marianne, okay. Yeah. So this is your question. So do you believe these implications last longer in patients of color? And how much more do you think dermatologists need to be aware of patient mental health compared to other specialties? I think in medicine as a whole, mental health plays a big role, but I think in dermatology especially, there's a lot of overlap, because a lot of people manifest their stress and anxiety on their skin. There's something called acne excoriae. There's something called trichotillomania, where people pick at their hair. There's something called Morgellons disease, or delusions of parasitosis, where kind of an OCD tendency, people actually can hallucinate little worms coming out of their skin. And they come in with like pieces of lint that they think are coming, like organisms coming out of their skin. So psychodermatology is actually a very, very interesting subspecialty of dermatology. And, I think that for people of color, they do have higher rates of mental health issues and a lot of stressors in their lives. So if you are a person with HS, if you have a low socioeconomic status, if you have other stressors related to race and your social situation, that can all compound to really make it worse. And, I've had a lot of patients tell me, they've said, you're the 5th dermatologist I've seen, and you're the only person that has taken the time to talk to me about my disease. So, every practitioner is different. And sometimes, and this is not an excuse, it can be really busy in clinics, just trying to provide care to a lot of people. But HS is one of those diseases where patients really do deserve a lot of counseling and reassurance and even an explanation of the pathogenesis, why this is happening to them, because of how much it affects their mental health. So I think that because of the nature of the disease, because it really impacts people's social lives, it's important to really address that as a pillar of care in these patients.
Dr. Chen, I actually have a question for you about working with other medical specialties in terms of diagnosing your patients? Has there ever been a case in people of color that you felt was exceptionally difficult to diagnose initially, and then you had to collaborate with other colleagues of other specialties? Can you recall something like that? Maybe an example?
So again, the most common situation were patients that would show up to the ER. The ER didn't know what to do with them, admitted them to the general medicine floor or to a surgical floor. Often these types of patients with abscesses that need to get packed would get admitted to surgery. Surgery wouldn't really know what to do with them. And if we were lucky, surgery would consult dermatology because they would have that inkling. They would say, okay, I think this is not a surgical thing. I think this is that HS thing, but let me just ask dermatology. And so that was really when I would see the patients when I was on service as a resident. I would see these patients and I would say, why are they admitted to the hospital? Because it should have started with the ED doctor probably 20 years ago that should have said, oh, this is a chronic inflammatory disease. Think of it like acne.
Yeah.
And let me get them plugged in with a outpatient dermatologist. And that saves the medical system tons of money. It saves the patient a lot of pain, a lot of frustration. And by the time that surgeon consulted me, that patient, I had patients that were their entire buttocks, both buttocks, down the gluteal cleft, completely scarred, draining, squamous cell carcinomas growing out of them. Like, I saw a lot of really severe HS because they had just been bouncing around from ER to ER, and nobody really plugged them in. So, I think that it's really important. I think dermatologists are the most aware of this disease. So that's why I think it's really important to give this talk. No matter what specialty you guys go into, you're going to see this disease. So if you can recognize it and get the patient appropriately treated, I think that'll give these patients a better chance at not progressing.
Thank you so much.
You're welcome. I think there's a couple of other questions. So yes, we do use topical antibacterials. I typically use Hibiclens soap, but panoxyl benzoyl peroxide also can be helpful. I have not seen any data looking at stress specifically associating with this disease, but a lot of diseases in dermatology are exacerbated by stress. And then a question from Rosalia, do you think there's a trigger to this disease, or is it usually during hormonal changes? So like I said before, I will go back to let's see if I can go back to my slide. The pathogenesis slide here. So here you can see that there's genetic predisposition to this disease. And some patients, hormones may exacerbate it, but not every patient. And that's because increase of androgens actually signal to your hair follicles to produce more sebum. So that can lead to more plugging of the hair follicle. So that may be why some people flare around their menses. But again, it's a multitude of different, it's a multifactorial process. So friction, obesity, smoking, those are all potential triggers to this. And then Ashley, charisma genetic. So, that's a philosophical question about why POCs are more prone to it. Again, we've located a few foci that show that there is a genetic predisposition. But, I don't know why this is more in people of color. Any other questions before I sign off?
No one else?
Right.
Well,
Thank you so much. Oh, thank you so much for staying the extra few minutes, Dr. Chen. We really appreciated you being here and answering all of our questions. Akta, if you had anything to add.
No, I just want to thank her so much for her time and her knowledge. It is truly always learning experience every time I talk to you, Dr. Shan.
Oh, thank you. Well, it was a pleasure. And, I think this is a really important knowledge gap. And so, even if you guys, take just a few little pearls and nuggets from this, I think it's valuable. So good luck. Best of luck to all of you on your journey. If you have any questions, feel free to message me. And yeah, you guys are all going to do great. I love seeing so many other women going into medicine, especially women of color. So it's wonderful. Keep up the good work.
Thank you
Thank
so
you
much.
so much.
Take care.
Yeah, thank you.
You're welcome.